This is working? Not it's only point.
It's not working. Okay, no problem. Okay. Good afternoon, and sorry for this interruption. So the technical issue in the laptop. We will start again a talk we started in the morning of prolonged ECMO, and we will try to answer a very important question: when to withdraw from a prolonged VV ECMO. Then this is my disclosure, and I want you to know some important notes. As the use of ECMO continue to grow, clinicians will increasingly confront complex and sensitive ethical issue. The ethical dilemma raised during initiation and conservation and withdrawal of ECMO. This debate of withdrawal was raised between the healthcare providers themselves and between the healthcare providers and the surrogate or the patient relative. In some countries, there is the withdrawal of care is forbidden, like in our country. Withdrawal of ECMO, ethics and approach is different from respiratory ECMO to circulatory ECMO, because simply we said that in circulatory ECMO we have a bridge to a more durable destination, but in VV-ECMO there is no chance for the patient either to recovery or lung transplant or withdrawal of care unless we bridging for nowhere. The challenge and on decision making: patient who is conscious and no multi-organ failure, communicating and interactive with surrounding, mobilized, not under sedation management, and he has been on ECMO for more than 100 days. I think this is a big challenge. Withdrawal of care, totally dependent patient on ECMO, that lead to patient crash immediately. Also, it will be very difficult for the surrogates, for the healthcare provider as well. It will raise an emotional stress on all of the team. Then again, the challenge in approaching the patient who is awake or his family and relatives, eventually the negative impact and emotional burden on the team, and never underestimate it. The factor claimed to raise this ethical dilemma that ECMO is typically initiated in a time-sensitive manner, and it's life-saving modality, no treatment, but it's a bridge, and this is a misunderstanding by the most of the family. Destination to long-term devices allow ICU discharge, not an option like in cardiac. We can do bridge for LVAD, and the patient can be transferred home for a year waiting for heart transplant. And I will let you go with this video. I think the video will not run. So I prefer to go through some of case scenario to deliver my message. Always do your best. In such case, 36 years old female patient, post-MVA with a blunt chest trauma, required ECMO support, multiple fracture rib and lung contusions with the pneumothorax, complicated unilateral bronchopleural fistula. She'd been on ECMO for 65 days with zero tidal volume. During the weekly ECMO ground round, the question was raised for futility, for sure, and this is the very worst time for me on treating an ECMO patient to discuss the futility on a prolonged ECMO patient. All the team agree that the patient is futile, no tidal volume, or the bronchopleural fistula, or the air coming from the ventilator escape from the fistula and leak, giving no chance for the other longer to heal. Then when we decide to the patient to be futile and discuss his code status, I raised one last option for the patient, which is independent lung ventilation. Actually, I searched for the picture or video, but it's not available now with me. This patient, we treated him with independent lung ventilation with 2 ventilators, and what's fortunate that 2 weeks later, the patient left lung improved dramatically, and then the right lung on day 82, patient transferred to rehab center to continue her rehabilitation and reconditioning with a spontaneous breathing and was decannulated out. The second case, I want to deliver a message with try all the time, search for an exit strategy. Here in this case, 16 years old, the patient supported on ECMO due to severe ERDS and septic shock. Post-spontaneous abortion. After support, the patient found to have pulmonary TB. Patient ECMO run went through a lot of serial complication because this patient kept on ECMO for 182 days. So you can imagine the rate of complication that happened during this time, from intestinal perforation and being operated, recurrent chest infection, aggressively treated, recurrent alveolar hemorrhage, till we reached to the day 120, almost the patient was stabilized out of complication, and we wait for the lung recovery. Patient continued to be dependent on ECMO to a point her state became stationary and no further improvement. At that time, we continue with our management and start to reconditioning her, mobilizing her in hope her lung improved, but it was not improved after 160 days. At that time, we're adapting her for higher CO2, so we could be able to downgrade the system from ECMO to ECOR. And the decision was not to escalate the management. And this is the first good step to do for your patient, just in case the patient is worsening later on. There's no option to escalate her management and return her back to ECMO. She take her chance. This is the first one. Then this was our exit strategy before we send the patient for a request for a lung transplantation in a lung transplant center. Because of TB, the patient was not candidate for lung transplantation, so we don't have any chance for this patient. We pushed to force decannulate this patient and shifted her care on maximum ventilatory support. Unfortunately, 1 week later on, after decannulation, the patient developed cardiac arrest from the prolonged respiratory acidosis, but we think that this was an applicable exit strategy for such kind of patient. However, we are all sorry about here. In case if we have implantable lung devices, this would be maybe a strategy for her later on. Hope it became soon in the market. 3, I wanted to deliver that don't give up. 41 years old female patient supported on VV-ECMO post severe ARDS due to H1N1. Totally white lung with zero tidal volume also for till day 85. Developed a lot of complication as well. Pneumothorax and hemothorax, been treated of heparin long time, and then extensive thrombosis of iliac and femoral vein. Again, in the multidisciplinary round, question raised for her fertility, and we decide that she is fertile and we don't need to go more invasive deep with this patient with invasive maneuver. However, at the end we decide to insert for her IVC filter. Eventually, no obvious cause could explain the totally consolidating lung, so we consider her fertile. Before we take the decision, one option was raised by one of the team to the patient has cannula site infection, which is no option to change the cannula because the patient was totally dependent on ECMO, and it will be very difficult. So we take the last chance for her to take the risk and change the cannula site, and it was successfully changed the cannula, and what happened at that time that we found a deep-seated abscess in the pelvis in relation to this infection, and we claimed that it's the septic focus responsible for her condition of the lung. And yes, after 2 weeks, the patient successfully improved and removed the ventilator and decannulated, discharged home after 104 days. Case number 4, don't prohibit process of death. Just when you feel that we are prohibiting the process of this, hold on. But be sure that you do everything for the patient. Like this patient, 65 years old, male patient, supported on ECMO, post-CVRDS, and H1N1. Patient was supported for 76 days. His course was complicated with aggressive, resistant, recurrent, severe infection, and the episode of severe hemorrhage, oral tracheostomy, site and lung, all hardly was treated successfully. Eventually, lung started to improve, and the patient downgraded to ECOR. During the process of weaning, and the patient was about to decannulate, the patient suddenly developed severe hypotension, impending arrest. The last option for us, or the last maybe the cause, is sudden MI. However, the ECG was showed no any sign of that. Despite that, our cardiologist kindly take the patient to the cath lab. It was negative PCI, so we don't find anything else rather than this is the process of this, and we are prohibiting it. So we didn't escalate the patient for VA-ECMO or any further escalation of management. The last case is Baghdad dwelling. 52 years old female asthmatic patient, supported an ECMO as well. It's ARDS H1N1. Actually, this year H1N1 strains was very, very aggressive. Most of the patient kept on ECMO for more than at least 50 days. After 114 days of ECMO run, patient showed improvement, successfully decannulated. 3 days later, start to worsening again and accumulating CO2. We sedated the patient, kept mechanical ventilation. 3 days later, she improved. Her CO2 wash, pH was normal. When recover her from sedation, she doesn't wake up and she doesn't do it. CT brain done showed intracerebral hemorrhage, eventually became brain death. So we don't have any other choice to decannulate this patient. So my advice is first toward for the decision maker, toward the surrogates and the patient family, discuss all possible complications clearly, and it's important to refer to the exit strategy in case of goals did not achieved. Keep close to the family time by time from the moment they sign the consent, and they get them updated of your future plan and the goals. Engage them in the patient care. Allow them more time beside their beloved one. Try to build the trust between you and them. Closely monitor their expectation and manage accordingly. And toward your team, don't forget your team, because emotional burden from this kind of surface is very hazardous for your team. So treat the emotional stress that may be reflected on your team, and never underestimate it. Join all the team members in this decision, debriefing and reassurance post decision. To the decision maker, keep your decision in a multidisciplinary approach. In case of withdrawal decision, try to escalate the support over time and cautiously. There may be a chance for survival, like what we mentioned before. Do your best clinically before decision. Also, we give an example for that. Confirm that there are no any other option you missed could help the patient, or any causes that could be reversible. Don't count day on ECMO. Run time should not be considered during the fertility discussion. ECMologist who can tell yes, again, he can say no before the support, especially in case of brain death. Take aside and never approach the family for organ donation. There should be a separate team who carry on and never allow them to communicate with the family. This for just only a conflict of interest that may be considered. Keep destination, target, and goal managed accordingly. Respect patient autonomy and willing. Respect neurological factor in your decision. In case of conflict, keep with the positive side. For sure, the patient will do it. Convince yourself first, and then the other team, then the family. Believe in miracle for somehow. Then thank you, and happy to get a question.
Thank you, Dr. Ahmed, for your nice presentation on a very contest topic. Now this session is open for question and answer.
So a lot of questions, very difficult. We don't actually reach beyond, I think, 40-45 days, probably less. So I do want to ask how you manage heparinization on these patients when they go up to 100, 105 days.
We go with the lowest PTT, sometimes from 35 to 45. Even for most of these cases, we get totally run more than 100 days of ECMO, but we're using HLS.
No filter change?
No, for sure. Actually, by the manufacturer of HLS, you should change the filter every 30 days. But sometimes we extend it to 45 even. Sometimes the patient developed some clots and kept on only for 2 days. Again, I didn't discuss the resource allocation because it's a major concern. But for me, because I'm interested to save these lives, that's why I ignore the administration and all this.
One more question. The first case, how exactly did you ventilate them?
Independent live ventilation, and it's actually I tried it 2 times, and it is very perfect in treating one kind of patient who have a unilateral bronchopleural fistula or bilateral bronchopleural fistula, but one is massive and the other is less massive, because in the bronchopleural fistula the air escaping or leak from the ventilator did not give a chance for the other lung to heal. So this is the best option for keeping half of the tidal volume for this lung by one ventilator, and the other ventilator support also the leak, or even you cannot support on the ventilator, keep it spontaneously, it do work.
Amazing.
Okay.
Very, very nice.
Okay. Any other question?
First speaker is here. Controlled mechanical ventilation protocol, vocal lung approach, and patient gradually improves, and then after 15 days or so develops nosocomial infection, VAP, and then goes into ARDS. Then what do you consider as a time frame as less than 7 days? Do you still contemplate giving ECMO in these patients, or do you consider it as a continuum of the same process?
Actually, previously it was a contraindication to support the patient who was previously supported in ECMO, but it depends on the patient condition from the previous ECMO support. That's why we used to make a detailed report for all patients who get an ECMO about their lung condition, and we following them in pulmonary unit for respiratory and pulmonary function test to evaluate their lung. However, the patient is still on the ICU and in the hospital. Still, we can take the decision if there is any hope, and his previous or first run was not complicated, and it was fasting course. We support the patient again on it.